Good evening, everyone. Please come up with queries. Good evening, everyone. Please come up with queries. Thirty-two number question. 32 number question is. Good morning, rather. Good morning, everyone. Please come up with queries. So, this is the this is what is the clinical criteria for the diagnosis. This is the clinical criteria for the diagnosis. Is it okay? So it has been once a PYQ, so I have mentioned it. See, if these are the clinical history of the patient, then you will say it accordingly. You will say it that it is the Apla syndrome, Sydney or modified Separo. Give us a clinical criteria on the basis of history. On the basis of history, we can diagnose the Apla syndrome. Okay, this was one of the PYQ in the postgraduate exam. So I write here, at least it has 4 points. If any one of it is present, you will say that patient is a client of Apla syndrome. Okay, at least one or more than one clinical episode of venous thrombosis or any thrombosis. Okay, it can be stroke also. Number 2 is at least one fetal demise, one or more than one fetal demise after 10 weeks. There is one abortion after 10 weeks. Number 3, more than 3 abortions less than 10 weeks. Is it okay? And in the last, at least one or more than one preterm delivery before 32 weeks due to placental insufficiency, uteroplacental insufficiency or severe preeclampsia, not mild preeclampsia. Is it okay? Is it okay? This criteria, if this criteria is present, then you will go for the lab diagnostic episodes of Apla or APTT. Then you will go for the lab. Okay, so this was it. If out of this one is present, then you will go with the lab diagnosis procedure. Otherwise, you cannot go. Okay. Next is eighth. I don't know why you do this wrong. Rupture. It is very simple. It is a case of what is the diagnosis? It is a ruptured ectopic. It is a ruptured ectopic. Since on per abdomen there is tenderness and rigidity. And on PV, cervical motion, tenderness is present. Can you tell me one more diagnosis of cervical motion tenderness? One more differential diagnosis? Yes. What is it? One, it is present in cervical motion tenderness, is present in ruptured ectopic. One more diagnosis. So, what is the treatment of ruptured ectopic? The treatment of ruptured ectopic is salpingectomy. Why you want to save a ruptured tube by salpingostomy? Why? Why you want to save the... It is not necessary that guarding is present. It is not necessary that... Very good, very good. It is cervical motion tenderness is present in PID. Dr. Rachna, it is not necessary that each and every finding will be written by the examiner. You can't say with all this diagnosis that it is unruptured. Okay. So you will do salpingectomy. Salpingectomy. If the vitals are stable, as said in this question, then you will do laparoscopic. If the vitals are unstable, you will do laparotomy. Is it okay? 37. Dr. Rachna has asked 37 and 44. Drugs used in PPH. Drugs there are 3 types of prostaglandins. Prostaglandin E1, prostaglandin E2, prostaglandin F2 alpha. The prostaglandin E1, another name is misoprost. Prostaglandin E2, another name is dinoprostone. And prostaglandin F2 alpha, another name is carboprost. Is it okay? This misoprost acts on for cervical rightening plus uterus contraction. Dinoprostone only does cervical rightening, and carboprost only does uterus contraction. Okay, so E1 is used in labor induction because it is doing the cervical rightening. It is also used in abortion induction because it is doing rightening. Plus, it is used in PPH because it is also contracting the uterus. Whereas E2 is used only for the labor induction and abortion induction, but not in PPH. The F2 alpha cannot be used for labor induction, abortion induction. It is only used for PPH. Is it clear? Rachna, Dr. Rachna, is it clear? 44. There are 3 types of shock after delivery, or you can say 3 causes of shock after delivery. Okay, so what are they? PPH, amniotic fluid embolism, uterine inversion. Is it okay? In the PPH, there is hypotensive shock and there is decrease in BP and increase in pulse, and patient expires after 12 hours, at least 12 hours. Is it okay? And this is the most common of all these 3. Okay? Amniotic fluid embolism, there is which shock? Can you tell me? Respiratory and cardiac arrest, followed by DIC, and patient expires in maximum 30 minutes. You can say 5 minutes to 30 minutes. So that is why the word out of proportion is used. Since DIC is occurring, so bleeding will also be present here. If the death of the patient occurs in 5 minutes to 30 minutes, or there is respiratory asphyxia, or the word out of proportion is used, then you will mark amniotic fluid embolism. You will not confused by the word bleeding. DIC में भी bleeding होती है. Okay. Let us talk about uterine inversion. In uterine inversion, there is neurogenic shock, that is extreme pain. Due to extreme pain, and there is decrease in BP and decrease in PPH. Okay, decrease in pulse and decrease in BP both. Okay, and there is also present hemorrhagic shock. Patient expires in 6 to 8 hours. Okay, right? So if it is given, the keywords will be extreme pain, decrease BP, decrease pulse, death after 6 to 8 hours, and more important thing, bleeding will be present here also. So you will not get confused with bleeding. You will look for the keywords. The keywords for PPH is hypotensive shock and death is not occurring, patient is still in shock. In amniotic fluid, you will look for the keywords. In the pph, you have to look for the another keywords that is most common, and death is not occurring because death occurs very late in pph. So you will they will only say hypotensive shock and bleeding. Bleeding is common in all. And if they say there is respiratory shock, or the death occurred in 5 to 30 minutes out of proportion, okay, or they can say you that confuse you with massive bleeding or cardiac arrest, then it is amniotic fluid embolism. And the last, in the uterine inversion, they will say you neurogenic shock, decreased BP, decreased pulse, extreme pain. In what is the diagnosis? Okay, let me take the another question. 125. Question number 1. Question number 1 says, karyo of partial mole. You all know that 2 sperms fertilize in molar pregnancy. Okay, 2 sperm fertilize in molar pregnancy. So if 2 sperms fertilize a ova, then it is triploid. And if ova has its own nuclear contact, then it will be a partial mole. Partial mole means fetus is present along with the trophoblastic proliferation. Right? So here it will be 2 sperms, 2 end from father and 1 end from mother. If mother nucleus is present, then it will always be the fetus will be formed. Okay, so whenever they say you partial, you know that the fetus is present along with the trophoblast proliferation. You know this thing, right? So in that case, you will, the first thing you will thought that along with 2 sperms, in this case 1 mother nucleus is also present because it is partial, it is fetus is present. So the answer will be 69. Okay, molar pregnancies have more chance if they have more X chromosomes. At least 1 X should be present. More are the X chromosome, more is the chance. Let us discuss the karyotype of complete mole. Here the diploid, 2 sperms fertilize empty ova, no empty ova. So what is the result? Complete mole. Complete mole means only trophoblast is proliferating and there is no fetus. Right? So the answer is, here it will be 2N 46XX, both paternal. Okay, sometimes they tell you 46XX both maternal, 46XX both paternal, then 46XX maternal plus paternal. Whenever they ask you karyotype, Whenever they ask you karyotype, you are going to think that whether mother nucleus is present or not. So mother nucleus will be present only if fetus is present. If fetus is present, mother nucleus is present, it will be 69. And if the um, it is a complete mole, no fetus is present, then it will be 46. And as no fetus, no mother, so all the paternal chromosomes. After 1, it was 25. 16. Molar pregnancy in the partial mole, beta, as there is fetus plus trophoblast proliferation. So you cannot say snowstorm. You will say it's snowstorm in the case of complete mole when only trophoblastic proliferation is present. In the partial mole, you will diagnose it as missed abortion. Only trophoblastic proliferation. No, no fetus. Okay, so this is snowstorm. Okay. Now the another thing, they will be confusing you vascular and avascular. So now you know that it is a complete mole rather than partial mole. Now what is avascular mole? The villi which are proliferating, the trophoblastic villi which are proliferating, they are avascular. They are avascular. Why they are avascular? Because no placenta formation. No placenta, no chorionic vessels. It is not a normal pregnancy that it will be vascular. It is a avascular mole. Okay? It is a avascular mole. The villi, they don't have vascularity. After that, it was 25. '25 was a wrong question. The question was possible cause of GTN. I have typed also all except. I have an emergency call. Till then, you please write the risk factors of GTN. Which case of molar pregnancy will go into GTN? I am coming in 1 to 2 minutes. Hello everyone, I'm back. The complete mole. Okay. So this was question number 25. Complete mole has the chances to become GTN. So what are the risk factor you think that Dr. Sheffi, it will be after 5 to 10 minutes. Okay. So yes, what are the risk factor that complete mole will change into GTN? How you will suspect that complete mole can change into GTN, but how you will suspect if the beta HCG is more than, a doctor should know whether the chances are there or not. Okay, beta HCG is more than 10 raised to power 5 in the case of complete mole. High chances that this complete mole will change into GTN. Number 1. Number 2, if there is formation of bilateral theca lutein cyst, instead of the values falling, the beta HCG is not falling. Instead of falling, it is increasing after suction and evacuation. Okay, if the fundal height is more than period of gestation, it means that there are large number of trophoblastic villi, and it means that soon there is large beta HCG. And number 5, if the age is more than 40 years. If in the molar pregnancy you see any one of these symptoms, you will say that this molar pregnancy will change into GTN. There are high chances. Okay. Is it okay? What is there after query? Dr. Kavita's query now. 22. Partial mole and complete mole. What is the difference? Can anybody tell me? First of all, there is formation of fetus plus trophoblastic proliferation. Here there is only trophoblastic proliferation. Okay, number 1. Number 2, already discussed here, because there are 2 sperms are fertilizing with 1 ova. So it is 69XXX. Here it is 46XX. Okay. Number 3, chances of becoming GTN very less, rare. Here it is 20%. Okay. And number last, which was asked, P57 and KIP2 staining, KIP2 immunostaining, positive in partial mole, or whenever there is maternal component. So maternal component is only present in partial mole. Is it okay? Next is 24. Here the period of gestation equals to fundal height. Dr. Kavita, whenever these question comes of abortion, where you have to identify the clinical type, what you will see in all these abortions, bleeding and pain will be present. So don't focus on them. Okay, so don't focus on them, right? Just see what it is written: os. If os is closed or os is open. If os is closed, then there are two options. Either it is threatened abortion or it is complete abortion. Okay, os opens to remove the products of conception. The cervical os opens to remove the concepts of conception when the myometrium contracts, right? So if the os is closed, it means myometrium is not contracting, or everything has gone out. Now myometrium is not contracting. So either it is threatened or complete. If the fundal height on PA is equals to period of gestation, then it is threatened. If the fundal height is less than period of gestation, then it is os closed. If os is open, then it can be what it can be? It can be it can be inevitable, incomplete, or missed. Missed is another entity. Let's not discuss it here. It can be inevitable or incomplete if os is open. In inevitable, what is there? The fundal height. It means the abortion is inevitable. It means that it nothing has aborted, but you cannot prevent the abortion. If nothing has aborted, it means it is fundal height is equals to period of gestation. Is it okay? And in the incomplete, the fundal height will be less than period of gestation because something has passed out, right? Something has passed out. So here it will be less than period of gestation, plus the patient will give you a history of passage of products of conception. Is it okay, Dr. Kavita? Dr. Ram, I'm not getting you what you have written here. Dr. Ram, I'm not getting you. Can you clarify that what means like secondary to infection, secondary to trauma, like that word? After infection, what is happening? Like after infection, TLC increases, CRP increases. That is the meaning of secondary to infection. After infection, what happens? Secondary to trauma. Secondary to trauma means what happens after trauma? There are bruises, there is bleeding. Is it okay? Question number 26. A G6P0L0 lady, history of recurrent abortion at 14. So there were 5 abortions in this patient at the period of gestation 14 to 16 weeks. What is the diagnosis? If only this much was given in the, what would be the diagnosis? Please be fast. Can you tell me? It is indicating cervical incompetence, second trimester abortion. But here the history changes and it is saying one abortion is missed abortion at 12 weeks. Okay, one abortion is missed abortion at 12 weeks. Okay, so here it is saying that all the abortions occur at 14 to 16 weeks, but then the history changed. One abortion occurred at missed abortion at 12 weeks. So it means it is not cervical incompetence because one abortion is missed. So what are the other causes of abortions? APLA, right? Other causes is APLA. Okay, so to diagnose the APLA, you will do lupus anticoagulant and anticardiolipin antibodies. Okay, because one abortion was missed at 12 weeks, so you suspect here and fetal anomalies, chromosomal anomalies also. So you go for fetal karyotype. Okay, next the patient is saying, next test which is given in your D option was VDRL. Many times we have discussed here that in syphilis, the law which the syphilis follows is Kessowitz's law. Kessowitz's law. What is Kessowitz's law? If the abortion is occurring at first trimester, then the next abortion will occur at second trimester and the next abortion will occur at third trimester, and next we will get a new baby. Not always the same. Okay, number 1. And one more question which is asked. Kessowitz's law is for early congenital syphilis or late congenital syphilis. So the answer is late congenital syphilis. Okay, because usually the syphilis present in the late second trimester. After that it is 26 is 30, 32, 35. This you have to mug up as per MTP Amendment Act. Contraception failure can be terminated up till 20 weeks. The rape victim can terminate its pregnancy up till 24 weeks, and the fetal anomaly, if it is present, can go up till any time. It can be terminated up till any time. Okay. Next is 32. 32 has been explained. Next is 35. This is Branded Andrews technique. Modified 35. Branded Andrews technique. What is it? My Branded Andrews technique says that you have to give controlled traction to cord for delivering it, and the other hand at uterus in upward direction. This is to prevent inversion. Counter traction. So basically it is for placental delivery. Is it okay? After this it is 48. What are the signs of uterus rupture? During the uterus rupture, the fetus comes in the peritoneal cavity. Okay, so there is superficial palpation of fetal parts on per abdomen. Is it okay? Fluid in the peritoneal cavity. And now the fetus will not be felt on PV. Fetus not felt on per vaginum, because fetus has gone in the peritoneal cavity. That's why. Okay. So this is also known as loss of station. So just remember these 3 lines and you will able to differentiate the uterus rupture. Any other query? Any other query? Can we close the session?